What's your work week like as a PA in the ER? I'm guessing a lot of you guys are new, but my work week, I work 3 days a week, typically 3 days a week. Sometimes it can be 4, sometimes it can be 2, but it doesn't really depend on the days that I work in the week, but the amount of shifts I work a month. So I try to only work 12 shifts a month. So hi guys. I know some people are having trouble getting in. Let me try. I'm just gonna give it some time because I know it's a lot. Hey guys, I'm the guest. I mean, not the guest, but I'm the presenter for tonight. We don't have a guest, so I'm just gonna give it a few more minutes because I know it's just kind of getting used to. Yes, everything someone asked about, will future meetings be on this platform? Yes, everything will now be via Zoom. And I'm not sure if you all know, I'm not sure if you guys all know, but we no longer have or require you to verify with like your hours with a certificate. So we're going by the honor code, which means that we're, honoring the fact that, you really did watch the sessions or do watch the sessions, and you're counting what you watch, only what you watch, of course. So please don't lie. And I mean, there's so much value in this. You learn so much. So yes. All right, I'm gonna get started. Okay, because some people were saying that they're still not able to access. I don't know, I guess I'll give it another minute. So you guys know that when I host eShadowing, it's more of like a Q&A type session. So I'll see all of your questions in the chat box. So if you have questions, anything PA related or application related, I'll be answering those. Okay, so I'll just start off with answering questions. Okay, we can do make this a full Q&A, or I can present a case study at the end. Okay, I got my first rejection letter today. Any tips on how to cope with it and how to stay positive? So I think that's gonna happen. You're gonna get rejection letters. In terms of coping with it, I would just say that, everything sounds kind of cliche, but what's meant to be will be. There's reasons why schools reject you, and a lot of times it probably doesn't have anything to do with you. But I mean, not that it doesn't have anything to completely do with you. You should, of course, reassess. And hi, Rachel. Hello. So I would say, of course, I would reassess, reevaluate your application, see where you went wrong. But in terms of that, schools just may not be able to accept, all students that apply. And PA school is very, very, very competitive. So I would just working on it, keep working on, where you went wrong, reevaluate your application, talk to the school, find out, what they liked, what they didn't like, how you can, make your application better. So yeah, and just as far as coping with it, yeah, I mean, cry, go through the motions. It's normal to do that. But then just, keep going. You got to keep going. You got to persevere. Like, the key is to persevere and realize that, if this is what you want, things are going to happen. You're going to get rejections. You're going to, get, go through failure, but you have to just keep going. And, yeah, that's all I can say is just to keep going. It will happen. You will become a PA. Okay, what drew you to emergency medicine and urgent care? I was drawn to emergency medicine and urgent care because of the variety within both specialties. You see so much in a day. So emergency medicine is very different, and urgent care both are very different from other specialties. The majority of specialties, when you work in that specialty, you just kind of see what's in that specialty, which is like, say you do OB, you kind of really see just, women. You see women and do women's health or mother baby. If you do rheumatology, you see rheumatologic conditions. If you do endocrinology, you see endocrinology, diabetes and whatnot, and those type of conditions. If you do family medicine, you like family medicine and internal medicine are another one where you'll see a good bit and have a lot of the opportunity to learn a lot. But emergency medicine is just like, I just love it. It's like I said, it's similar to internal medicine and family medicine, as in you seeing a lot. but I just like the fact that you're treating acute conditions and the setting of it, and, you know, being able to see patients, treat them, you know, either send them home, admit them, transfer them, whatever the disposition is going to be. But I love the fast-paced nature of the ER. I felt like it aligned with my personality and the setting that I wanted to work in. And so that's why I chose it. But it was really because you're just constantly learning new things, and you see so much in a day. You're not going to just see cardiac cases. You're going to see, you know, people with chest pains, people with abdominal pains, people with flank pain, people with, you know, nausea, vomiting, you know, just strokes, heart attacks. You'll see everything. You'll see like non-emergent cases. You'll see stuff like, you know, that are just not ER, but then you'll see the actual emergent cases of people, you know, traumas, people actually dying and needing you. So yes. Okay. I see a lot of questions coming in. Is it okay that I document my degrees that were earned this month, this May, June on my application, although they haven't technically been awarded yet? So if you already graduated, you can document it. But if, you know, as far as the actual degree, like your diploma, yeah, it can take months. But if you've already graduated and you have the transcript, like it's going to be on your transcript, or you have access to the transcript, then yes. I'm going into my freshman year of undergrad. Any words of advice? It's great that you kind of already know what you want to do as a freshman. Not a lot of people know that. I would say as a freshman to still explore various majors and degree paths. You know, you don't have to make a decision. You don't have to decide. If you decide PA, yes, that's great. But you don't have to decide PA like as soon as you walk, or decide on any career as soon as you walk into college. I think so many students are pressured to choose something like right then and there when that's not the case. Take your time. You know, whether you want to give yourself a semester to explore various career paths or majors, but just really be certain that, you know, that this is what you want, and explore, like do all your research, start shadowing. I think one of the best things to do when you know, say, oh, I'm interested in PA, shadow will really let you know if this is, you know, what you want to do. I mean, this kind of shadowing, but if you can get in-person shadowing, that's really helpful. And of course, virtual shadowing, being able to, you know, do this and see, get in a webinar where PAs are talking, where you're learning about their day in the life, the work that they do, what it entails. That's great as well. So I would just say do all your research to try to get like hands-on experience. So yes. If you don't have any acceptances by December 2022, should you assume that you probably did not get accepted into school for a 2023 start date? No, a lot of acceptances, a lot of schools start like accept students literally up until like the day before school starts. They'll get people off the wait list. So I don't think you should say, oh, it's completely over. I would probably wait until April or May, maybe when CASPA opens again and you still don't have something, yeah, but, and then I would say by December, if you don't have something, then maybe kind of prepare to reapply, but it doesn't mean that it's done. You can definitely still get an interview, you know, and even March, schools are still interviewing, so that's me. What's your work week like as a PA in the ER? I'm guessing a lot of you guys are new, but my work week, I work 3 days a week, typically 3 days a week. Sometimes it can be 4, sometimes it can be 2, but it doesn't really depend on the days that I work in the week, but the amount of shifts I work a month. So I try to only work 12 shifts a month. So I like space those shifts out. So sometimes I'll do 3 days or 4 days, but yes, and I work 10-hour shifts, and I create my own schedule for the most part as a travel ERPA. So yeah, that just gives me a lot of flexibility, and I work basically 120 hours a month. So being that I travel, I'll drive to work. I drive 2 hours to work. I'll stay at a hotel during that time, and then I'll basically go into work, clock in. I'll clock in via our computer system. This is just kind of a run through of my day. I'll clock in via our computer system, or our software, which is Epic. Our charting system is Epic. You clock in, and then you'll see your tracker board. The tracker board has like all the, you know, patients in the ER, patients in the different areas of the ER, whichever section you're assigned to. The ER I work at is just typically myself and the doctor. Another PA or NP comes on later in the day. depending which shift you work. So it's 2 shifts for the PA or NP. So if I work morning shift, then the PA or other NP come in later in the day. So when I come in, it'll just be myself and the doctor. So it's not like, oh, you're in a certain area of the ER. You just have the whole ER, just you and the doctor. So you just pick up patients wherever they are. Sometimes the doctor, of course, if like a trauma comes in or a level 1, the doctor will typically take that. But for the most part, I just pick up whatever patient needs to be seen. If it is something super complicated, I kind of see that the vitals are crazy, then I'll let the doctor know or leave it for the doctor. But like I said, 90% of the time, I'll be seeing those patients, any patient that walks in the room as well. So I will see patients that need to be seen, or the tracker will show patients that need to be seen, and I pick them up. Usually when I come in, it's some patients that need to be seen. So I pick them up and I pick up all that I can, and then I just knock them out. But the first thing I do is I review their chart really quick. And I say to do that. When you review their chart, that gives you an idea of what you're working with, what you're about to go into. So I'll look at their vitals, I'll look at their past medical history. I look at, like, kind of skim through their charts if I have time to do that, just like their past visits, just to give you like a little synopsis of that patient and that patient's history. So if you have a patient that comes in with chest pain and you look through their chart and, they have, they had several stents placed, they had an echo done recently, like they have a cardiac history, then you know that, oh, okay, this is a patient that, may be experiencing real chest pain. And this is a patient that I might have to do 2 troponins for versus 1, or that may need to be admitted, and that already has risk factors. So you already start working things up in your mind, just from looking over the chart. So then I'll go see all my patients. I'll, introduce myself and do a history, a physical. It's very similar to what I do when I do the case studies with you guys. Do my history, my physical. From there, I'll start like thinking of a differential. And I think of differentials as soon as I see the patient's complaints, for the most part as well. So yeah, and then I'll history, physical, do that on all the patients I have to see, history, physical, talk to them. And then I go back to my desk. And then when I get back to my desk, I order labs, imaging, all that the patient needs, medications, and I'll do that on all my patients. So I just kind of built up a system and my own style of, seeing patients and my flows, just so that it works for me and so that I don't get too far behind, even though sometimes I do, most times I do get behind. So start ordering labs, imaging, medications, do that for them. I do my charting last. I don't go sit and chart because you want to order everything and kind of get everything, cooking while you're doing your charting. So once you're done charting, then things are coming back in. So when you finish your notes and you got, stuff, your lab results are coming back, imaging is coming back. So then by that time, you just kind of figure out your disposition for that patient. Like, what are you going to do for this patient? Are you going to, what's the diagnosis? Are you going to send this patient home? Are you going to admit them? Are you going to transfer them? And that's when it gets tricky because, labs are never what you see, what you learn in school. It's never straightforward. You say you have a patient with heart failure, that's septic. And, if you have heart failure, they got to be on fluid restrictions. But if they're septic, then they need fluids. So it's never cut and dry. It's never like, it's always complicated. It's always something in the ER. So yeah, and that's a lot of the times when I'm consulting with the doctor as I'm getting my results back. And that's when the teamwork it's constant teamwork, but I think like the most important, especially in the ER, is when you're trying to figure out what to do with the patient and what's going on with the patient, because that collaboration really helps in getting that insight from that physician and learning from the physician. Like everything that I've learned and getting my comfort level has been from learning from, experienced PAs and NPs and doctors, of course. So yeah, that's basically it. Once, I figure out a disposition, get those patients admitted, discharged, whatever it is, then I just keep doing that. That's just my flow. So that's a run through. Okay. So let's see. I got caught up. Okay, I forgot which question I was at. Okay, I know that's the question now. Okay, this is my first time applying on a cycle. Is it normal to reapply to the same school the next cycle, as I am worried that my application is not sufficient enough for this cycle? Yeah, this is my first time applying to 6 months. Is it normal to reapply to the same school the next cycle? Yeah, you can reapply to the same school the next cycle. Yes, if that's what you're asking. Yeah. You can reapply to the same school as many times as you need to. But of course, show that you've changed, show that you've improved, whether it's, you know, whatever you did, whatever kind of held you back, work on it. So if your grades that were holding you back, work on your grades. If it's your patient care hours, work on your patient care hours. I would see a rejection as just like improvement, like the need to improve and giving yourself time to improve. I don't see it as like, oh, you're a failure, oh, you're not going to be a PA. Just work on yourself and you'll be far more ready to conquer PA school when you take that time to improve. And that's for the student that said they got their first rejection as well. So, and I've had several PA guests come on and talk about, like, I actually think the majority of our guests did not get into PA school the first time. So many of them said, oh, they were reapplicants. I believe one PA applied to PA school 4 times before she got in, and then she got into Duke, which is like the top PA program. So yeah, and if you've gotten rejected, I would also like go through like have that inspirational moment, like talk to PAs that were PAs, hear their story, talk to various people, students in PA school, how many times they got rejected or how many times they've had to apply, and you'll learn and see. Like the acceptance rate is 30%. That means the majority of people did not get accepted the first time. So there's nothing wrong with that. Okay, as a PA, what responsibilities do you have on a daily basis? I think I kind of answered that just in terms of my scope as an ER PA. Just as a PA, you'll see a lot of the same patients that the physician sees, and your responsibility is to, you know, evaluate, diagnose, treat, be basically at the forefront of that patient's care. So you're going to be, you know, there, you know, giving orders to, you know, the nursing, radiology, whatever it is. So you have to know, you don't always have to know, but you have to be ready to kind of lead, but well, yeah, basically lead the team and lead and collaborate, lead and work as a team. So yeah. Okay, I answered that already. Will you be showing us any cases today from your job? Geez, I think I already did this case last week or the week before, and a really interesting case I had. I think I already did that though, but I can talk about a case that, like, interesting cases that I've had. I didn't necessarily present or prepare a case study like I normally do, like a presentation, but I can talk about like cases that I've had. Is it difficult to find a job for a full-time PA position? No, not especially if you have experience. If you have experience, it's really easy to get a job as a PA, I mean, in my opinion. What are your most effective study techniques from PA school? Okay, I like talking about study techniques. And anything I talk about is just based on my experience, so it doesn't always mean that it's right. Wow, there's also Q&A right here. I didn't know there was a section for Q&A, so I'll answer those Q&A questions as well right after that study technique. Study techniques. Okay, so one thing I believe in is the rule of 3s. I don't know if it's just the mind thing, but it seemed to work for me in PA school, so I would study everything at least 3 times. And the way that I studied is that I would first go over the PowerPoints. Your PowerPoints are going to be extremely long, like hundreds and hundreds and hundreds of slides. And it's not just one PowerPoint that's like 200 slides. You'll have like several PowerPoints. Like one time I had like 800 slides total to review for a test. So you'll have very lengthy PowerPoints. So I would review all of those PowerPoints, all my PowerPoints. And then I would review my notes. So your notes are actually like notes, like written notes or typed notes. And I wouldn't do them myself. I would get them from like students, or like they'd get them from a past class or something. You'll have access to notes. I mean, I think now you can even buy notes. So then I would review the notes, and then I would create my Quizlet cards. If you know, I love Quizlet. So I would create my Quizlet cards and I would type them myself. And I found that when I typed them, it also helped me memorize and learn too as I was typing. And then I would like review them. So that's what I did. And I would do that 3 times. So I would review Quizlet 3 times. I would review my notes 3 times, and I would review the PowerPoints 3 times. I just learned that the rule of 3s and repetition is like just key to like learning. The more you see something, the more you're able to really understand it. So that's just something that I do. And, you know, let me know if it's worked for you. I've had students tell me that it worked for them. So yeah, the rule of threes, just reviewing everything 3 times. And Quizlet, the Quizlet flashcards, I would just keep going over those. And then the day before a test, I would do that. I would spend the whole day like kind of doing that. And I would make my Quizlet cards the day before test as well. And in the morning of the test, the only thing I would look at are my notes, like my actual like written notes from like students or whatever. So yeah, that was my technique. And then I would supplement that with like YouTube. YouTube was the best thing. I think YouTube is like one of the greatest inventions, like being able to like search and watch videos, especially if you're a visual learner. Yes, Khan Academy really helped me with anatomy and physiology. Yeah, YouTube. Yes. Just as like supplemental, like if I still didn't understand something, like I can read something over and over and over and I still don't understand it, but then I watch it on YouTube and I'm like, oh, okay. So yeah. What PA school did you go to? I went to Nova Southeastern University in Fort Myers, Florida. Okay, got that. How would you recommend finding a PA to shadow in person for a letter of recommendation? I've tried reaching out so many times, but no one has gotten back to me. First of all, I would not, you don't ever go into, her question was, how would you recommend reaching out to a PA for shadowing or the letter recommendation? Don't go into shadowing thinking that you're going to get a letter of recommendation from that PA. The PA is not obligated to write your letter of recommendation. If you want to be strategic about it, you would show that you deserve the letter of recommendation. So don't say I'm going to shadow to get a letter of recommendation. Say you're going to shadow to learn about the PA career and you know, get acclimated and learn about the day in the life. And then from there, you may get a letter of recommendation. You're not going to always just get one from shadowing a PA. You know, if you worked close can you guys, oh, it froze. Okay, now it's back. Yeah, you're not going to get a letter of recommendation from, or they're not obligated to write you, I'm sorry, it just like frozen, acting crazy. They're not obligated to write you a letter of recommendation. What I mean by being strategic is going in there, you know, building relationships with them, being nice, talking to the staff, showing that, you know, you want to be a PA, showing that, you know, you're there more than just to sit and watch, asking questions, being engaged, maintaining a relationship with the PA. Don't make it like a one and done type of thing. If you shadow for a week or you shadow for 6 weeks, I say to at least try to shadow for 6 weeks because that gives them a sufficient time to get to know you. If they say, oh, you can come shadow for a day, okay, you probably do your day, but then you'd be like, okay, I would love to come back, you know, whenever, you know, you have an opportunity, I would love it, blah, blah. So you have to show that you want it. You have to stand out. I've heard that students go to shadowing and they sit there and they're like just on their phone, and, you know, you're kind of ruining it for others when you do that because shadowing is, you know, kind of hard to get. So yeah, don't go into anything thinking that you're going to get a letter of recommendation. It's great to get one, but you have to just go there for the experience. If the PA doesn't write you one, that's fine. You're there for the experience of learning about the PA career, not to get a letter of recommendation. Yes. In terms of connecting, finding a PA to shadow, of course, you guys can use the MedSembly app, my app. I'll put the link below to connect with PAs. We're always adding new PAs on there. So you can do that. And you don't always have to just say, oh, I want to, you know, connect with you to shadow. You guys have to think about like building relationships and long-term relationships. And that's also how you're going to get a recommendation from somebody, you know, remaining in contact with that person, not just kind of using them just for something because you need it for your PA school application. Like, it's being a PA is far beyond applying to PA school. This is going to be your lifetime career. So you have to see it for that. So, yes. And I mean, you can also utilize LinkedIn, Facebook groups, any way that you can connect with a PA. What's the best way, in your opinion, to get patient care hours? I was an LPN. You don't have to be an LPN. That's probably one of the harder ways to get it. What I really like, of course, is medical assistant, certified nursing assistant. Those are the ones that, you know, there's not really a gray area for that. You know that schools probably 100% of the time are going to be fine with you being an MA or a CNA. Is a bachelor's degree required to get into PA school? Yes. I believe so, yes. How did you prep for interviews? What type of questions should we prepare for? Definitely ethical questions. Those are a little harder to answer. Definitely ethical questions. Those were some of the ones that I was like, okay, like one ethical question that I got was that you see your classmate cheating on you, what would you do? Like cheating on your test, like you caught them like looking over your test while you were taking your test. And I said, because I'm not a snitch, I said that I would talk to my classmate and I would find out, you know, like how I can help them learn so that they wouldn't have to cheat. I said that would be my first thing to do, is try to help my classmate. I ended up getting into PA school, so I guess they liked my answer. I guess because I'm more so about supporting them than kind of just throwing them under the bus. And, you know, you never know what people are going through. So that's why I said that. So yeah, I mean, a lot of ethical questions, there's not like a right or wrong answer unless it's blatantly wrong, but I would go over ethics too, because they'll ask you that. And I would talk to yourself a lot, talk in the mirror, get used to talking, just talk, get used to, you know, talking. If your session is like a Zoom, then, you know, do this, just practice in the style of the interview. So practice with others, practice smiling, practice talking, practice your why, answering tough questions. So yes. Did you take the GRE? If so, do you have any study tips for it? Yeah, I took the GRE. And as far as taking the GRE, it was a blur. I didn't study as much as I should have. I did fine on the GRE, but I started studying for it months before, but I wasn't actively studying. Like I would kind of more so passively just with the flashcards, because I know that the reading probably wasn't, not reading, but vocab probably wasn't going to be my strongest. So I started using flashcards like passively 6 months. Like I would, you know, take them everywhere. I would, you know, go to be at the hair salon, like going over my flashcards, be at the nail salon, whatever, going over my flashcards, try to memorize like 10 words a day or something, you know, use them in everyday life. So I did that. And then I also did Magoosh. I mean, I swear by Magoosh. I really like Magoosh. I don't know about you guys, but it worked for me. So that's why I always recommend using Magoosh. We partnered with Magoosh as well to offer a discount to students, like a $50 discount. I can give you guys the link here. But yes, there's the Magoosh discount if you want to use Magoosh. So that's what worked for me for studying for the GRE. Somebody said Magoosh and GregMat. Yeah, so yeah, and GregMat I heard is good too. Do you feel like you get to spend more time with your patients as opposed to a doctor? That's the thing, like I hear students say that and I'm like, I don't know. And I'm just speaking from the ER. I don't see that I spend more time with patients compared to a doctor. I think it's the same. Like students say that in terms of their YPA. And I think it's also similar to students saying that they want to be a PA for work-life balance. And people can, you know, argue that and say, oh, not every specialty has work-life balance. Because if you're in surgery, you know, it might, depending where you work and how busy of a practice it is, you might not have good work-life balance. So I wouldn't use those as to your YPA, the fact that you spend more time with patients, or the fact that you have work-life balance. I don't really, in my opinion, think they're like super strong points, because I don't feel like I've spent any more time with the patient than the doctor. And I think in terms of spending time with patients, is how much you want to spend time with your patient, is just how much time do you have to educate that patient. That doesn't come with every specialty, you know, and also like how busy you are. You're not going to have time to really, really, really spend time with patients. And that's just, you know, and it's not you, it's not anything you're doing that's wrong. It's just, you know, how busy, like things that's out of your control. So I don't think it's a PA thing. What made you want to be a PA instead of an NP? Because I'm gonna answer a few more questions and then I'll go over a case study. I wanted to be a PA instead of an NP, and that's a good question because I was already a licensed practical nurse, right? So I wanted to be a PA because when I learned about the PA career, I realized that it was the best path for me. I'm all about like, you know, not overcomplicating things. So I found that I already had a lot of the prereqs for PA school. I had, you know, the experience, the patient care hours. And then I liked the fact that I would learn similarly to how they, you know, are taught in medical school, because it's the medical model. So that's something you guys can use in your like kind of YPA in your essay. But yeah, so for PA school, that's why I chose PA, because it aligned with what I wanted to do. I was able to learn as a physician, similarly to how physicians are taught, with the heavy science background. So yeah, that was my main two things. Okay, let's see. Do you recommend pre-PA joining any memberships? If so, which ones? Sure. Yeah, I think that'll definitely help you. Of course, it won't hurt you to join memberships, and it'll help you connect with PAs as well. I would definitely, and that's another thing, if you're wanting to connect with PAs, is to join your local organizations. Your state organizations. Like, you know, if you're in Georgia, we have GAPA. If you're in Florida, there's FAPA. If you're in New York, I'm sure there's a NAPA or something, or NYAPA, or I don't know. So I would probably, the state organization is probably the one where you're going to be able to meet PAs, you know, within your state to possibly shadow. So you can do that. And then of course, AAPA is the national organization. You can do that as well. But if you really want to find PAs within your state, probably joining the organization for your state. So wherever you live, put in like, Association of Physician Assistants. So if it's like the Georgia Association of Physician Assistants, the North Carolina Association of Physician Assistants. So yeah. I hope my questions are, I hope this is bringing value to you all. Okay, I think I answered all the questions. I think I got all of the questions from the Q&A. I didn't even realize there was one. Alrighty, and I think I got all the questions from there. Okay, let's see, case study. Interesting case. I'm just gonna say one from off the top of my head. I haven't actually worked since Thursday, so I'm trying to remember what interesting stuff I had. Oh, okay, I had, so a patient came in, presented with tachycardia, and she initially presented with like side pain or something, and she was tachycardic, I believe. And so if a patient presents with like side pain or flank pain, what would you be thinking? Like, what would be in your differential already just from the complaint? You guys can type in the question, your answers. If a patient came and complained side pain, not like abdominal pain, even though it's still in your abdominal region, but like flank pain or side pain, they kind of just call it my side because they don't know flank. People are saying appendicitis. Appendicitis is a complaint for that is more right lower abdominal pain rather than side, but like lower, like front. So kidney infection, good Taylor. So kidney infection would be in your differential. What's another common one? Very common. It doesn't necessarily mean an infection, but it can mean something else. Stones, yes. Awesome, Taylor. Kidney stones, yes, Nicole. So yeah, so those are some of your differentials, that they could have a kidney infection, also called pyelonephritis, or a kidney stone. So this patient, she was young. So just kind of working her up, and her blood sugar was also high. So she was a diabetic. She was type 1, pretty sure type 1. Yeah, she was a type 1. She was a type 1. So she came in and she was complaining of side pain or abdominal, one of them. So she was admitted, and no, before the admission, just talking to her. Sorry, guys. So she said she has this pain, and she's been seeing a GI. Sorry, it was abdominal pain. It was abdominal pain, not side pain. It was abdominal pain. So she's been seeing GI for like forever for it. And she'll get these infections, she says, or she'll get these things wrong with her stomach. I don't think they've ever really gave her a diagnosis. So I basically worked her up. What do you think I ordered based on her complaint? Her complaint was actually like abdominal pain. My bad, guys. Abdominal pain / high blood sugar or whatever. So what do you think I ordered? Like as far as blood work. Remember, we always talk about blood work. So what blood work after talking to her? CBC, CMP, pregnancy. Good job. Pregnancy test is a must. Any female of childbearing age pregnancy test. Urine test, yes. So you guys have all of them, you except for one. All of them except for one. And when you think of abdominal stuff, LFTs go in the CMP. If you order a BMP, then you can order LFT separate. DK can cause abdominal pain. Lipids, no. So think about the organs in the abdomen. Think about the organs. So we think about our pelvic organs. So because, making sure it's not pregnancy. So then what else is in the stomach? We think about appendix. So we do a CBC in case they have a white counter infection, not A1C. You don't really order A1C in the ER, but what else is in your stomach? So we said our pelvic structure, liver. Yes, good job, liver. That's liver. We already said liver function, but what's near the liver? What's another thing people kind of forget that's near the liver? Spleen, you're gonna get gallbladder. Yeah, you're getting there, but gallbladder is gonna tell us more. Pancreas, good job. Yes, pancreas, good job. Chantel said that. Okay, first. Yeah, pancreas. So another complaint of, so differential diagnosis for abdominal pain is huge. Like if you think about all the organs that make up our abdominal area, the pelvic stuff is gonna have a crap ton of stuff. Then the liver stuff, think about your liver, think about your pancreas, think about like your spleen, think about your gallbladder. So there's so many possible things that could go wrong with abdominal pain. But the good thing is that the majority of the imaging that we can do can figure those out, what that is. So all you got to do is some imaging, but you got to figure out what imaging to do. So pancreas, so what test would you order to make sure it's not pancreas related or pancreatitis? Amylase, lipase. Yes, you guys are so smart. Oh my gosh. Like I didn't know any of this. So yes, but lipase is more specific than amylase. So sometimes some people will order an amylase, but usually I just do a lipase. If they do in fact have pancreatitis, and you can add on an amylase, but you'll learn that lipase is the test to go. It's way more specific for the pancreatitis. So I'm not saying that she has pancreatitis, guys. I'm just saying like tests to order based on the complaint. So those 5 tests, any patient with abdominal pain, I start off ordering those 5 tests. If it's a female, of course, you're gonna add a pregnancy test. So CBC, CMP, lipase, UA, pregnancy test. And those kind of will target everything abdominal related. Excuse me. So we did those tests, and it came back that her potassium was like incredibly high. Like, wait, is it high or low? I'm trying to remember. Yeah, it was high. It was high. Her potassium was like crazy high, and her kidney function was like crazy low. Like she was in some real renal failure. Like she could have had to have a dialysis, and she was young, guys, like young, like younger than me. So that's a straight admission. Hyperkalemia, hypokalemia, like mild hyperkalemia, if it's, you know, you can correct it, but hyperkalemia or hypokalemia, that's severe, admission or moderate and has EKG changes, because the, you know, potassium can affect your the electrical activity of the heart, brain fart. So you really want to, if the patient has hyperkalemia or hypokalemia, look at the EKG, making sure there's no EKG changes, so because they can go into terrible arrhythmias. So this patient was going to be admitted no matter what, like just straight admission. But the next thing is like treating her condition. So say a patient has renal failure and hyperkalemia or like abnormal potassium. It could be because she's in renal failure that she has the crazy high potassium, but which are you guys going to correct first? Are you going to try to get her dialyzed, or are you going to correct the potassium? What are you going to do? Yes, good job, Nicole. You would correct the potassium because you don't want her to like go into like cardiac arrest or nothing. So you would correct the potassium. So being that she's the diabetic, to correct the potassium, there's a lot of things that you can give. You can give calcium gluconate, you can give potassium, not potassium, you can give calcium gluconate, you can give insulin drip, you can give albuterol, you can give K-exolate. There's a slew of things that you can give all those combined. But she needed to treat that hyperkalemia. And I think it's probably is because she's in renal failure. She told me that she had kidney problems, but I didn't know it was that bad. And it could be because she's a diabetic, but I honestly don't know why she was in such bad renal failure. But she was also throwing up. But that would more so cause hypokalemia. So she was just a little, like, the case was just a little complicated. Either way, she was going to be admitted, but acutely in the ER, we're going to treat, as you guys said, we're going to treat her potassium pending admission, treating her potassium, making sure she's admitted. We did a CAT scan of her abdomen and pelvis, and it shows that she had like stranding around her kidneys. I think either one or both kidneys. Her urine didn't look too bad like a UTI, but basically she also had pyelonephritis. I think that's why I started with the flank pain or side pain, but I think it was more abdominal pain that she was complaining of. But when you have pyelonephritis, you're going to have that side pain or flank pain complaint. So she also had that on top of the all the issues that she had going on. So we had to start her on antibiotics, making sure she wasn't septic. Let me see. So that's kind of just, she had to be admitted. We started her on insulin and glucose because of her potassium. So insulin pushes potassium in the cells so you can become hypokalemic. So a way to treat hyperkalemia is to give insulin. So we gave her some insulin, but she's also diabetic, so you don't want to drop her sugar too low. So we had to also give her some glucose on top of that and really monitor her and keep checking her sugars to make sure that, you know, she wouldn't bottom out or anything. So yes, that's just an interesting case that I had this week or last week, sometime recently. And the doctor was concerned because, you know, she was like so young and, you know, had all these complications, and he was saying that she might eventually end up on dialysis. And this is just to say, like, just from my experience, I've seen 30-year-olds on dialysis. It's really devastating, actually. That, you know, people are so young and have to go to dialysis. Dialysis takes up so much of your time. It's like an all-day thing, and to go 3 days a week, like that's like a full-time job. Just in terms of this, I'm done with the case study, by the way, guys. I guess it wasn't really a case study, just kind of telling you guys about my day and getting you guys to think and learn. But just to also touch on stuff that I see in the ER. It's not really interesting, but every patient that I see has diabetes or hypertension. Every single patient. I mean, I'm not gonna say every single, but the majority of them. There's not a day that goes by where I don't have a patient that has a medical history of hypertension or diabetes or both. And it's really devastating. And it's not, I don't think it's just a local thing, like just based on geographic location. I think is just everywhere, because I've worked in several areas, like New York, it was the same thing, Georgia, Florida, all of that is the same thing. So yeah, and that's the cause of a lot of people being so young and ending up on dialysis. So you guys take care of yourselves. And I do think that medicine, they're not doing a good enough job at like prevention. I mean, not just medicine, but just making sure people eat what they're supposed to eat and what we put in our foods. That's ruining us, really, really ruining us. Yeah. Did she already have dialysis? No, she was not on dialysis. Like her kidney function dropped significantly from the last time she was seen. I don't know if she actually ended up on dialysis. I did check on her like a few days after, but I didn't check on her. The next few days, I don't think she ended up on dialysis, but I don't know if she was like the course. I don't know the full course of her visit. It's type time, imagine uncontrolled type 1 diabetes affects rural lower income. And okay, yeah, and speaking of type 1 diabetes, I also had a patient, I just like talking about like interesting stuff with you guys. I also had a patient that was a type 1 diabetic, and she would come in constantly in DKA, and that's not something that you want. You don't want to be constantly in that state. And she was in her 20s as well, and the doctors, I would feel so bad because the doctors would say that she's not going to make it to 30 because she's like in such a terrible, like her health is so terrible. Like diabetes is one of the worst things. Like if you're a type 1 diabetic and you can't control it, you were born with this, like take control of it. Like you can't control the fact that you have diabetes, but you can control like what comes with it and making sure you live as healthy as possible. Yeah, it's terrible. Yeah, and insulin, the cost of insulin is insane, like insane. Do you get a lot of COVID patients anymore? I actually have been getting, like, interestingly enough, like one COVID case a week, like, and then like 2 weeks ago I had like 2 or 3. Since I've been working on this new travel assignment that I started in April, I think I've had a total of 6 or 7 I probably 10 now, because I had a family that had it, like a family of 3, they all had it, mom, dad, child. So I think I've had a total of 10 COVID cases since I started working in April. It's definitely, of course, not as bad as it used to be, but yeah. Can diabetes happen with age? Not to say that if you get older, every person that ages is gonna get diabetes. Diabetes happens when you're, unhealthy lifestyle and, not managing your health. So it's not, you're at a higher risk for it because of, as you age and, becoming more insulin resistant. But yeah, it's really more about your lifestyle. You can be 90 years old and not be a diabetic. So yeah. Which test helped you determine that she had a kidney failure? Her kidney function. So the creatinine, BUN creatinine, and the GFR. GFR is the glomerular filtration rate. So that would tell you if she's in renal failure. It's a complicated process. Anybody that does nephrology, have I ever had a nephrologist PA come in? I've never. I think that's what I need to get for you guys, but nephrology is very hard. But looking at those will tell you if the patient is in renal failure. Like you want your GFR to be at least greater than 60. Of course, greater than 90 is ideal. But in the ER, it's like if it's anything like less than 60, they have some level of renal failure. And hers was like 10 or 12. Like hers was like low. So, and then when it gets very low, I mean, when your creatinine gets, I don't remember exactly like stage 5, when they'll need dialysis, but hers was probably low enough to eventually get dialysis. And then with also dialysis, if it's affecting your electrolytes like potassium, like magnesium, like sodium, all of that, then they'll need to get dialyzed too. So yeah. We have a few minutes left if you guys want to answer questions, if you want to hear about another interesting case. I'm trying to remember cases that I had last week. Interesting case. Okay, interesting case. Trying to recall. Dang it, I'm trying to remember what cases I had. I had to admit a patient. I had to admit like 3 or 4 patients in a day. Oh, okay, interesting case. Okay, so I had a patient that came in, and it's pretty straightforward. So I had a patient that came in with a hemoglobin of a hemoglobin of 5. What would you guys do? A hemoglobin of 5. What would you do? Transfusion. And I kind of talked about this before, but so as your transfusion, good job, 2 units blood transfusion, but like what else do? You already know like the hemoglobin and hematocrit, they kind of go hand in hand. Blood screen, okay. So if a patient comes in with something, you're not always going to find out the why in the ER. You're kind of just finding out like the what's going on. You might not always know why it's going on, but in the case of someone losing blood, you have to find out why, right? Or you have to have an idea of what could be causing them to lose blood. So if they come in as a trauma, you know it's the trauma causing the blood loss. So if they come in and they're perfectly fine and they walk in and they have a hemoglobin of 5, what would you do? Good job, Nicole. So she said a GI bleed. That's a very common cause of low hemoglobin. So a CT scan is not necessarily going to show a GI bleed, but what is going to show you a GI bleed? What would you do? It's nothing nice. It ain't nothing nice. Yes, Taylor, good job. So you're gonna look at the stool, rectal exam. Yes, Nicole, yes, you guys are killing it. So you will do a rectal exam. You got to go in there and see if you see any blood. So yeah, so that's, yeah, if you don't see blood, then it's probably something else, but more likely than not, you're gonna see blood. And for our ER specifically, we have to make sure of that, because if it is a GI bleed, the patient needs to be transferred because we don't have GI services. So that's why that's important to do. So in the case of blood transfusions, yes. So if it's a woman, what can be causing her to, have low hemoglobin? Period. Good job. Yes. So menstrual, yes. What necessarily kind of menstrual related or woman related? Miscarriage, okay, that's something like kind of acute, but what long-term can, cause your periods to be out of whack and cause, a lot of issues? PCOS, not necessarily. Endometriosis. This is common in Black women. A lot of the cases that I've seen it with this has been Black women or minorities. This woman was not Black, but yes, fibroids. Good job. Yes, fibroids is a big. I've had a patient come in. She was a Black woman and she was like middle age, and she actually fainted. She had a syncopal episode, and her hemoglobin was like in the 4 range. It was so low. She had to be admitted into the ICU. And she had fibroids. She had like a lot of fibroids, and I believe they were big too. So that's why I say you have to know that that kind of a why for for anemia. And anemia, I think I told you guys this already. When would you transfuse? When would you transfuse for anemia? Yes. Yes, good job. Dang, Nicole is on a roll. Yes, you would transfuse when the hemoglobin is equal to or less than 7. So if the hemoglobin is less than 7, they need a blood transfusion. I've also heard that I also know that, but if they're symptomatic and it's like around 7, 8, some people would, do a blood transfusion as well. But yeah, hemoglobin less than 7. You're gonna see this on PA school tests. So just know I told you first. Yes, I'm glad that you guys learned that. Yeah, fibroids is very common. It affects Black women commonly. Yeah, there's studies on that too. Another word for fibroids is leiomyoma. But yeah, this patient was tentative to have a myomectomy too. Myomectomy is like the removal of fibroids. And the indefinite treatment, I mean, you can have a myomectomy and I believe it can come back, but definite treatment will be like a hysterectomy. What is the normal range for hemoglobin? It varies by age, like 12 to 16. I just know that whatever I see on the on the labs. Like it depends on not age, yeah, it can depend sex, like women versus men. So yeah, like 12 to 16. I mean, you'll see in your lab test what's normal, abnormal. The labs that I definitely remember, like ranges are white count. I just always know 5 to 10. Potassium, I always know. Sodium, I always know. Yeah, hemoglobin, I always like 12 to 16 range. You guys have any more questions? I know I didn't have a full-on case study, but I hope you guys were still able to learn from just kind of running through various cases and scenarios and just kind of working out how you would treat it or different things you would do, or, you know, just how to handle certain things. No problem. Any other questions? But it's next week. We'll hopefully have a guest and it's going to be awesome. So yes, you guys have no problem. Good job, guys. So this is how it's going to be from now on. So have a wonderful night, guys. As always, point is to learn. So as long as you're learning, so have a good night, guys. Bye-bye.